Well, thank you, Chris. I'd like to begin by thanking the King's Fund for establishing this commission and my fellow commissioners for the experience of working with them. Our deliberations have been harmonious and our conclusions have been unanimous, and I hope very much that the summary which I am now going to give will fairly reflect what is in the report and what was said during the course of our meetings. But before turning to that, I should just like to make one personal point. Some 20 years ago, I was chairman of the Civil Aviation Authority during the high noon of Thatcherism. And I saw then how very damaging it can be when government conflates reductions in the public sector, reductions in public sector expenditure, with denigration of those who have to carry them out. Of course, at a time like the present, management and administration costs must take their fair share of the pain. Let there be no mistake about that. But the greater the degree of change, the more the government needs the support of and leadership of the public sector managers to achieve its objectives. And what happened 20 years ago was that the denigration of the public sector became so intense that good people left, good people wouldn't join, and far from becoming easier, it became more difficult to achieve the objectives. Now, this point has a particular resonance so far as the National Health Service is concerned. Politicians of all parties fall over themselves to praise doctors and nurses and to boast about increasing their numbers. But too often they unite in expressing disdain for National Health Service managers and in boasting about reducing their numbers. This contrast is both absurd and damaging. For one thing, many of those holding management positions are indeed qualified doctors and nurses. For another, the distinction between those involved directly with patient care and those involved in management is often very blurred, with both working towards the same objective. Let me give just 3 examples which I take from the report, but people in this room would be able to produce many more. One that we give is that to operate efficiently, surgeons need theatre managers. Another is that likewise, general practitioners need receptionists and to have their appointments managed. And the third that we mention is to raise the question of as to what part of a 999 call centre does the service cease to be frontline. The call takers and the paramedics are clearly frontline, but they can't function without information and communications technology, and indeed without having their vehicles properly serviced, so that the distinction between what is frontline and what is support is a very blurred one. And the truth is that a good and effective NHS requires good managers if good doctors and nurses are to deliver good health care. To the extent that managers are denigrated, so good people will be deterred from joining the NHS, and those that are there will be encouraged to leave. Moreover, doctors and nurses will be discouraged from taking on management functions, which is the exact opposite of what we believe the NHS needs. We want management and leadership to be shared equally between managers and clinicians and equally valued by both. At a time like the present, when the NHS is having to make unprecedented cuts and to carry through far-reaching changes, the role of management is particularly important. Quite simply, maintaining as far as possible frontline services and standards of care when resources are being dramatically cut by 6 to 8%, maybe even more, in some acute trusts, requires a very high degree of management expertise and indeed of management commitment. Take another contemporary example. In place of the single measure of whether or not a 4-hour wait is breached, the Secretary of State is instituting 11 measures of A&E performance. The new system has undoubted merits, but it will require more management time and it will cost more. Or a third contemporary example, the proposal for GP commissioning consortia means that 200 or 300 new consortia will take the place of 150 PCTs and 10 SHAs, and the creation in local government will also lead to some 150 health and well-being boards. In other words, the demands for management will increase rather than diminish as a result of some of the changes that we're seeing. Against this background, the government is aiming to cut administrative costs by 33% and the number of management posts by 45%. As I said at the outset, management and administration must bear their share of the pain. There's no question about that. But these figures do appear to be entirely arbitrary and backed by no published analysis. We therefore ask the Secretary of State to provide the analysis that has led to these figures, to let us see the rationale on which they are based, and to be willing to revisit those figures if it turns out that the rationale is faulty or merely taken out of the air. The members of the Commission have sought to provide data on whether or not the NHS has too many managers. Now, it's very hard to be precise, as database definitions vary between the Office of National Statistics, the National Health Service Information Centre, and other sources. Caveats must therefore be entered in respect of all comparisons, and it is a broad rather than a precise picture that emerges. What is clear, and everybody knows that, is that management numbers have risen, but they've risen relatively modestly by comparison with the increase in turnover and the demands made on the service. For the United Kingdom, the figure is an increase of 28% between 1997 and 2010, during which period expenditure doubled. Interestingly, in England, where we saw the massive changes involved in the introduction of foundation trusts, the internal markets, and targets and performance measurement, there was an increase of some 37%, while in Scotland, Wales, and Northern Ireland, where these innovations did not take place, the numbers remained virtually steady, indeed a slight decline. And this bears out my point that change in itself tends to require managers rather than a reduction. Now let us try to put this increase into a wider context. In England, the absolute increase in senior manager and manager numbers between 1999 and 2009 was just over 20,000, while the increase in professionally qualified staff was just under 184,000. On a full-time equivalent basis, the number of managers rose from some 2.7% to some 3.6% of NHS employment. Now, as far as we can see, and bearing in mind the caveats that I mentioned earlier, we sought to make some comparisons. The ONS, the Office of National Statistics, puts the proportion of managers in the UK workforce at 15.4%, while the NHS Information Centre, on a somewhat different definition, reckons that hospital and health service managers across the UK, the percentage is some 4.8%. Very different. Our report provides several other sets of figures, as a result of which, with due modesty, and again I point out that there are different databases, but with due modesty, we reckon that of the Department of Health's £100 million budget, some 8 billion is spent on management within the department, within the SHAs, the PCTs, and the providers of care. That is, less than 10%. In the United States, where charities have to categorize such expenditure, some big health charities spend very much more, and the two examples that we give are the Mayo Clinic at 12.5% and the Salk Institute at 19%. So, ladies and gentlemen, if the NHS is not overmanaged, why is it that we all feel entangled in a great bureaucracy, and why does the NHS give that impression? One reason, which we must accept and which goes with the territory and about which I do not complain, is accountability. We must be accountable, not just to our patients, but also to government, to Parliament, and to the local communities of which we are an integral part. The nature, sensitivity, and scale of NHS operations mean that this is bound to be immensely bureaucratic and time-consuming. Records and paper trails must be kept. Explanations and justifications are required. The number of central and local government committees before which we must appear are very numerous, and we don't have very much choice as to whether or not to appear before them. All of this is of a completely different order from anything in the private sector, and indeed from many parts of the public sector. But if we shouldn't complain about the burden of accountability, those who justifiably impose that burden should also not complain about the administration that is required to fulfill the obligations. Moreover, as Chris mentioned, there is another factor on which government could and should act, and I refer to the burden of administration. The NHS organisations are, we estimate, subject to some 35 different regulators, auditors, inspectorates, and accreditation agencies. That number has grown almost year by year in recent years, and even now, when government is aiming to reduce administrative costs by 33%, the process continues with constant changes in the remit of regulatory bodies, adding a further complication. A review of that burden, leading to a rationalization of these demands, is absolutely essential if costs are to be taken out of the system. Central to the performance of the NHS in future will be the quality of its leaders and its managers, and that's something which the Secretary of State paid tribute to in his speech. As numbers are reduced, in line with government policy and economic circumstances, so improving the quality must be a priority. We particularly want more clinicians involved in management and applaud the creation by the Royal Colleges of the Faculty of Medical Leadership and Management. But we urge government not to allow the abolition of SHAs and PCTs to have a detrimental effect on leadership and management development. Much of the current spending in this field comes from the SHAs. That role must in future be taken up by the larger foundation trusts and by the commissioning bodies. We also believe that there is a role for regional and national bodies, and that a national leadership centre could play an important part, and I was pleased to hear what the Secretary of State had to say on that subject. We believe, too, that NHS managers should be exposed to and benefit from best practice outside the service. We therefore encourage links between NHS bodies on the one hand and business and management schools on the other. This can take various forms. One is tailor-made courses that are tailor-made for people from the NHS. Another is the involvement of NHS personnel in general and or subject-specific courses where they would be mixing with people from other walks of life, other parts of the public sector, the private sector, and so forth. The King's Fund, of course, already provides leadership development for both clinical and non-clinical staff, and it too has a role to play. But I can't leave this subject without making one further point. All of us are aware that there have been some notable NHS management failures. And the names, of course, the role is well known to us all: Bristol, Maidstone, Tunbridge Wells, Mid-Staffs. And we don't believe, so something does indeed need to be done to take account of that. Our view is that professional accreditation is not the best way to handle this problem, but we do believe that a more effective way must be found to debar individuals who have been capable from holding executive posts in the future. And of course, as in other walks of life, it is very important when errors and mismanagement has occurred, that those who are held responsible are not unduly financially rewarded in the terms on which they actually leave the service. Now, finally, ladies and gentlemen, I'd like to touch very briefly on two governance issues. The most high-profile aspect of the government's reform proposals, the one which has attracted most public parliamentary attention, most attention in other areas too, is the creation of GP consortia, or commissioning bodies. I won't go into detail on this, but we feel that what the Select Committee has said about the proper governance of these bodies is absolutely on the mark, and we support the recommendations of the Select Committee in that area. One of the things which I find surprising, coming as I do from an acute trust, and I mentioned this when I was with other coalition peers in the Department of Health yesterday, is the contrast between the very prescriptive rules relating to foundation trusts and NHS trusts and the much less prescriptive approach that is being adopted in relation to GP consortia. And there is an element of riding two horses that are going in different directions in that respect. The other governance point, and it's a big subject and I can't, if I'm to keep to time, cover all of the points, but the other point which concerned us and which has not received very much attention, indeed hardly any attention, is an issue emerging over the governance of foundation trusts. Over time, bespoke regulation by Monitor is going to cease, and these foundation trusts will become much more genuinely freestanding businesses. Now, this is going to place a huge responsibilities, not just on the boards, to which reference has already been made, not just on the boards, but also on the governors. And they are, in fact, going to become something akin to the supervisory boards, which we see in the private sector on the continent, especially in the German-speaking countries. Now, that's a very heavy responsibility. It requires a very great deal of technical expertise. It's all very well to say that people should receive training to fulfill that function, and so indeed they should. I mean, it is going to be very important that governors do receive training to enable them to fulfill their functions. But we do worry that there is going to be an imbalance between the very great responsibilities that are going to be laid upon the governors on the one hand, and the qualifications of those who become governors, given the process by which they do so. And I believe that this too is something that needs to be looked at again. There is also a real danger of deadlock between the governors on the one hand and the boards on the other, and of governors second-guessing what the boards are trying to do. And that is not going to make it easier to attract good non-executive directors, a question which was raised earlier. That's not going to make it easier to attract good non-executive directors to the trust, something which is already quite difficult given the numbers required, the time that needs to be devoted, and so forth. And finally, ladies and gentlemen, I do urge the government, or we urge the government, I should say, we urge the government to live up to its words about distancing ministers from day-to-day involvement in running the NHS. At a time of financial stringency especially, but at other times as well, this will mean the boards must sometimes have to take difficult decisions about closures and the transfer of services. If the NHS is to take advantage of new forms of treatment and undertake the capital investments involved, there will also have to be massive strategic reconfigurations. These are bound to create corresponding controversy. As I indicated earlier, we are committed, we are bound to accountability. We do have to go through a whole raft, and it is right that we should, of consultations to prove, to demonstrate that what we want to do is in the best interests of the service and will enable standards to be increased and costs to be reduced. But when all those procedures have been gone through and when decisions have been taken, it really is absolutely essential, if ministers want boards and managers to be far-sighted and daring, and to exercise leadership, that ministers should back the boards in taking decisions which are difficult, whatever the complaints from political allies or indeed from political foes. So, ladies and gentlemen, that is a summary of the report that we have produced. I hope I have fairly reflected the views of my colleagues. I believe it is an important contribution to debate. I hope very much that the government will pay close attention to what we have recommended. Thank you.
Thank you very much.